We're welcoming back our speaker today, Dr. James Patrick Murphy. He is a Louisville native and 1985 graduate of the University of Louisville School of Medicine. He's a former United States Naval flight surgeon, having served aboard the aircraft carrier, the USS Enterprise. He completed specialty training in anesthesiology at the University of Louisville and founded a successful anesthesia practice in Elizabethtown, Kentucky. He left Kentucky for specialty training in pain medicine at the Mayo Clinic in Rochester, Minnesota, where he also served as an attending physician and instructor in anesthesiology. Dr. Murphy went on to earn board certification in addiction medicine, then a Master of Medical Management from the University of Southern California. He has been honored by the designation of Distinguished Fellow of American Society of Addiction Medicine, and he represents the American Society of Addiction Medicine on the Paid Care Task Force of the American Medical Association. He is currently the president of the Kentucky Society of Addiction Medicine, medical director of the Murphy Pain Center, and is on the gratis clinical faculty at the University Louisville School of Medicine. He is board certified in addiction medicine, pain medicine, and anesthesiology. So welcome back, Dr. Murphy.
I have the illusion of control now, so I feel much more safe. So, having said that, it's a pleasure to be here. It's an honor to be here to speak with you and hopefully help navigate some of this sometimes confusing subject matter about these levels of care of the American Society of Addiction Medicine. It's a nomenclature, it's a process, and we do need to learn this in layers. It's not something that we're going to master in one program or 1 hour of looking at it. But I want you to be familiar with it because it is the nomenclature and it's a way that we can communicate with each other, hopefully take better care of our patients and get proper reimbursement from the third-party payers so we can continue our care of our patients. I want to point out that the opinions that I'm going to give here are my own. And although I am I'm with various organizations, I don't represent any organization at this time in this presentation. These are my own opinions, and this is for informational purposes only. Having said that, let's move forward. Oh, maybe I don't have control. There we go. I'm very much enamored of this disclaimer slide, but I can't get it to go forward. Okay, and the financial disclosure, I don't have any conflicts of interest there. This is a necessary because we are in need of standardization in this rapidly changing field of addiction medicine. So the ASAM criteria and the ASAM levels of care are a way that we can fill this gap. Our objectives, I'm going to try to explain the ASAM criteria again, what that is, so we understand what that is, and where the levels of care, the ASAM levels of care, how they spring forward as a result of the ASAM criteria. Think about how to incorporate the ASAM criteria and the levels of care into our everyday practices. So as an outcome here, I want us to at least be familiar with the basic elements of the ASAM criteria and the ASAM levels of care so that we can use them. So we're going to hopefully answer these 4 questions. Understand what is the ASAM levels of care, how do the levels of care relate to the criteria, and why is it important, and then where can we learn more? And this is the talk I gave last week, and so I'll basically review some of the things we did last time, and then we'll have the Q&A, and we'll look at some scenarios as well. The ASAM criteria comes from this book. It's actually a textbook. If you can see me here, I'm holding it up. It's a textbook that you can purchase, and it goes into great detail into what the different criteria are and the levels of care and how to refer patients. Specifically, we can do it and look at it broadly to understand it. But I want you to know there is a lot of specificity with this as well if you want to get down to the details on it. And it's designed to help payers and healthcare systems ensure they're offering a full continuum of care to meet our patients' needs. So, based on the ASAM criteria, which uses six dimensions, and I'll go over those to create a holistic and that biopsychosocial assessment that's so important. And there are 4 broad levels of care. And so the ASAM levels of care are essentially 4 levels of care based on 6 criteria. So we'll go over those. There is a thing called the ASAM Continuum. It is actually a service that you can, like a subscription service, software that you can get, and it will help you conduct the proper multidimensional assessment and also help determine what levels of care the patient should be referred to. It's really, really helpful. And if you really want to get into this and you want to have a software that can help you, you can go online and subscribe to the ASAM Continuum and learn more about that. And I'll touch on that again a little bit later. And there's also a thing called the ASAM Levels of Care certification. It's in its early stages. And what that does is that allows programs to be certified that they're able to provide certain levels of care. And right now I believe there's just 3. So as I mentioned, there are 4 broad levels of care. Well, within each level of care, there's levels of care, sub-levels of care. For example, there's a 3.1, 3.5, and 3.7. And all 3 of those are ones that I believe you can be certified in. Your program can be certified. And what that does, being certified, think about JCO, think about the other certifications you can get. This is through CARF, which certifies rehabilitation centers. And what you can do with the certification is then gives you an extra level of, again, a credential. It also shows patients, it shows insurance companies, third-party payers, policymakers, that your program can do certain things, that you've at least been certified to do certain things. So it's a nice thing to have. It's a nice thing to have on your wall. It's a nice thing to go through. And by going through the certification, I've done this before for pain management in these others and at hospitals too. By going through this process, you tend to uncover things that make you a better organization anyway. So just want you to know that if there are lots of programs in Kentucky that are already certified through the ASAM Levels of Care certification, and I'll tell you how to find those later on. But it's becoming something that's becoming more recognized as a good thing to have for your organization. All right. So before we really launch into this, we have to understand the 6 dimensions of the ASAM criteria. As I talked earlier, the ASAM criteria is about assessing patients, and then based on that assessment, you can refer them to the appropriate level of care. So if I am going to have a patient come to me, and for any condition, say I'm in the emergency room or in my clinic, somebody has a chief complaint. Well, I'm going to ask them, gather information. Some of it's subjective, some of it's objective. I'm going to make an assessment, come up with a plan. And the 6 dimensions of ASAM criteria are really applicable to people that are battling the disease of addiction. I mean, if this was diabetes, it'd be something else. It'd be hypertension, something else. This disease happens to be addiction. And there are 6 criteria that when we're assessing these patients that really help us be successful. And I'll go through them 1 through 6. Number 1 would be the dimension of acute intoxication and withdrawal potential. So when somebody is presents to you, the first thing you need to make sure is they're medically stable and they're not going through withdrawal. And if they are, you must treat that and address that first. So you're assessing the level of and the potential for withdrawal. The second dimension is the medical issues. Is the patient medically stable? You're not going to be able to treat the addiction well if their sugar is off the chart, or if they're having a stroke, or if they're having chest pain, or other things that could go on that are just medically are just getting in the way of it, or something maybe not as even as acute as that, but just something that really interferes with you being able to get them the proper care. So you must address the biomedical conditions and complications. The third dimension then is the emotional or cognitive conditions and complications. And again, that's not even necessarily an addiction specific dimension, but it's oftentimes a comorbid condition or something that's occurring at the same time. If somebody's having a schizophrenic break, or if somebody's severely depressed, or tremendous anxiety or a panic attack, you can't get them into group therapy. You can't get them into some other sort of cognitive behavioral therapy, uh, something that you might want to do for their addiction treatment, until you've assessed and you understand that you've got a handle on what the emotional issues are. So those first three, I think of those as the ABCs. Think about like those of us who have taken advanced cardiac life support or basic life support. Think of the ABCs: airway, breathing, circulation. Well, these are the ABCs of the ASAM criteria: acute intoxication, biomedical conditions, and cognitive conditions. So acute, biomedical, and cognitive, the ABCs. Once we address those, then you have to assess the patient's readiness to change. So if are they there against their will, or are they incarcerated, or are they being forced to come in, or are they hit rock bottom? Is this a time where they're now ready to be open to it? And if not, then what do I do to get them maybe closer? Do I do a motivational interview? How do I get them closer to their readiness to change? But at least I need to assess that. So there's no sense in putting somebody in a residential treatment program when they have no intention of changing and there's no readiness at all. So you want to assess that as well. And the next one would be their relapse potential, or the potential for continued use. So you want to assess what is the risk with this person that they're going to, once they have their treatment, relapse, and you want to make sure that you are preparing if the potential is high, that you're ready to address that, because all the treatment in the world acutely does us no good if they immediately relapse. And we know that's a real risk with and commonly an expected outcome of addiction treatment, but we want to assess that. And then the sixth one, which is oftentimes I don't think we as professionals tend to leave this off, but a lot of care people, especially in an acute situation, don't give enough uh, interest to the recovery environment. That's number 6. So when they are out of the treatment, are they in an area? Have we improved the mnemonic, the persons, places, and things they're going back to? Is it, have we done something? Have we helped them with their social situation? Do we know about their social situation? The employment situation? How about, the marriage, or the kids? I mean, they have children, their job, where are they living? So the recovery environment is very important, the 6th dimension. So if you assess all of those things, you can kind of figure out, well, based on these 6 criteria, this is where they need to be in terms of the care I'm going to refer them to. So the first 3 are ABC, and the last 3 are R's: reading, writing, arithmetic. They're the 3 R's: readiness to change, relapse potential, and recovery environment. So if I'm going to think about a mnemonic, ABC, RRR, and then maybe don't have to pop open the textbook, but I would as we're learning this and we're incorporating this, I would love for everybody to be able to be familiar with at least the ABCs and the three R's of the that constitutes the six dimensions of the ASAM criteria. Now, based on these criteria, I've assessed all six dimensions, and I'm going to refer my patient now to a level of care. And there are four basic levels of care. Level one is outpatient treatment, essentially. And again, I want to point out that in each level of care, there's sub-levels in there too. Like I mentioned 3.1, 3.5, 3.7. Those are ones you can be certified in your program. So there are others as well. So I've got to point out level 0.5. That's one too. That's early intervention. Those are people that they really don't have enough information to diagnose them with a use disorder. So, but you're doing things to help, counseling, things of that nature to help prevent it. It can be one-on-one. It can be a group or something of that nature. But it's preventive, and it can be personal as well. Interventions. That's level 0.5. Level one is really more personal, and you do a more comprehensive evaluation of that individual patient, but it's outpatient treatment. Level two is the intensive outpatient, or within the level two is the partial hospitalization. If they refer to level three care, it is residential. They are living there. They are inpatient, or they're inpatient. So within the level three, it goes from the residential to full inpatient. And level four is the most critical one, where there is a medical management issue, and they need intense 24-hour monitoring with medical management as well. So realize there are four levels. And so when you're referring somebody based on your six criteria, which I mentioned, to a level of care, you're going to be able to decide which level of care, and also be able to ask for the third party payers to allow them to have this level of care based upon the criteria that you've assessed them. Based on that, you recommend a level of care. They get to have the level of care, hopefully, and it gets paid for as well, so they can continue and do their treatment. Because we do know that payment, this is it's just a fact of the life here, is a big barrier to people getting treatment sometime, and this helps people get the insurances to cover the treatments we want to offer them. So these are the four levels, with 0.5 thrown in there as well. Now, this is a chart that kind of shows the process together. The horizontal bar up there is the continuum there. So the starts with 0.5 on the left-hand side, early intervention, onto outpatient services, and then intensive outpatient. By the time you get to 3, it's residential. As you're going through the level 3 up to 3.5, it's the clinically managed and high intensity residential services. 4 would be medically managed inpatient services. So, my ability to sit here and explain to you the nuances and the specifics of each of these is, I can't do that in the time allotted. It wouldn't be fair anyway. You need to know that they exist. There are 4 levels, that there are subsets in each level, and then you can find with the help of the ASAM continuum, which I mentioned earlier, the software, and then getting familiar with the book I showed you, you can kind of become more familiar with where somebody fits in. So now that was the overall review, and I gets kind of bogged down sometimes in a lot of details here, but now we're going to be able to go into some questions and scenarios. There are questions that we have already submitted, and that And we've kind of found some scenarios online as well, which are kind of classic scenarios, which illustrate some of these subjects here. So we're going to go through a couple of those at first, and then I think open up to questions from other people. Okay, here's a question. Is there one particular dimension that trumps the others, or are they all weighted the same? Remember the 6 dimensions of the ASAM criteria. You know, the analogy I like to point out is like a basketball team. Now, I mentioned there were 6 dimensions. Basketball team has 5 players, and they all have roles. And if you have one that's clearly not holding the water, then you're not going to win. Here's an example. I mentioned this last week. Say, for example, the University of Kentucky was playing a basketball game, and we had 4 great players, all-star players, and then they asked me to be the 5th player. I can tell you that no matter how good the other 4 are, we're going to lose that game because they would score on me every time, the other team. So you can't have a weak link in this. In the ASAM dimensions, all 6 of those dimensions need to be addressed. If one of the balls is dropped, if one of those players is clearly not addressed, then the chance of success goes down quite a bit. Now, but as I mentioned, like the ABCs of the advanced life support and basic life support, airway, breathing, circulation, they are in that order for a reason, not just because it's alphabetical, but when somebody is having they've collapsed, the first thing you have to address is their airway before you can really do anything about their breathing. If their airway's obstructed, all the rescue breathing in the world's not going to push any air through the obstruction. So the airway must be open. Then the breathing, you must be able to move air, because you can't really go on to see the circulation aspect of it unless you're able to get oxygen in there. So they're in that order for a reason: the airway, and then assess the breathing, and then address the circulation. With the dimensions, it's kind of similar in a way. ABCs. Number 1 is the acute intoxication, and you really can't have meaningful therapy for addiction unless they're stabilized, both from a withdrawal standpoint and then also from a medical standpoint. So B is the biomedical. So A is the acute intoxication, B is biomedical, and then C is the cognitive and behavioral issues. So once those 3, in a sense, comorbid issues or medically related issues are addressed, then the other dimensions. But you address them in that order, but all of them are essentially weighted the same. But there is an order in which you should go through them, 1 through 6, and that does make sense. A, B, C, R, R, R. Next question. Are there placement criteria for each level of care? Well, there actually is. Each level of care, based upon the assessments you make with the ASAM criteria, and there are graphs in this book I showed you, and the ASAM continuum will help you do that as well. It will definitely give you criteria to decide which level of care is most appropriate, which is one of the important aspects of this whole process, is so that we're kind of doing the same thing in terms of where we're sending patients and how and the levels of care we're giving to patients. And that's also why it's important that we don't just like half follow the ASAM criteria or just kind of know a little bit of it. If you're going to get into this, and I recommend you do, really get into it and learn it and do it the proper way. The the ASAM actually, they want you to agree to, it's copyrighted in a sense and trademarked or whatever. They want you to agree to, if you're going to invoke the name of the ASAM criteria, they want you to agree to do it correctly, so that we have a uniform way of doing this. I got to tell you, it's really gaining a lot of traction all over the country, and the thought that you can get away without using this, I think, is becoming less and less able to do that, because just like people that resisted the ICD codes for Medicare and CPT codes, things of that nature. I mean, it's annoying at first, thinking you have to write down a number to, instead of a diagnosis and just describing what you see as a clinician. But it's the way that healthcare has evolved, so that we're speaking the same language in a sense in diagnoses. And it is no different with the ASAM criteria and the ASAM levels of care. So yes, there are placement criteria for each level of care, and I recommend that if you're going to do this, you learn to do it correctly. How can a non-clinician use the levels of care to help their clients? Well, I think that by non-clinician, we're thinking about administrators, uh, people that are uh, maybe working with payment, things of that nature as well. The administrative staff, and these are also, I would throw policymakers in here as well. People that are at Frankfurt, people that are deciding how we're getting paid to do this and how we're getting reimbursed to do these things, how we're going to make these things services available. Non-clinicians can understand a bit about how what these levels need and what each level of care requires of the facility, and then help give the facility, the clinicians, the resources they need to qualify for these levels, and then also help with the documentation, and help with give them the tools they need. Perhaps as a non-clinician, you would learn how to provide the ASAM continuum software for your clinicians. One way would be just to buy a book, buy one of the ASAM criteria books and have it in the facility. Start learning that. So allow your staff to get trained. There's several training modules on the ASAM website. There is, if you just Google or just look for the ASAM criteria, ASAM levels of care, you're going to see there are multiple opportunities to get training on these various aspects of this. So it's something that if you want to learn about it, and I recommend you do, it's out there. You're going to be able to find lots of help in learning how to do this. So the non-clinicians can participate in making this available, and then learning the modules themselves. Next question: are there resources for anyone that wants to seek out ASAM certified providers and facilities? So actually, there is. As I mentioned, the CARF, C-A-R-F, they have a search engine on their website, and you can put in there what sort of program you're looking for. And if you hit a drop-down menu in the advanced, it'll say, it'll show you. You can pick the state you want to look for, and it'll say ASAM levels of care certification 3.1, 3.5, 3.7. Click enter. I did that last night, and I could see all of the facilities in Kentucky that were 3.1 certified, that were 3.5, 3.7. So this certification through CARF, it's not hard to find through their website the facilities in whatever state you're in that have done the certification. ASAM itself, also, you can go and you can find certified providers. Now, with the certified providers for ASAM, they used to they used to offer ASAM certification. That morphed into the American Board of Addiction Medicine, which still exists. But the American Board of Addiction Medicine is in the process of morphing or evolving and becoming taken over by the American Board of Preventive Medicine. Now, all of this you can access from the ASAM website. So if you go to the American Society of Addiction Medicine website and look up certified provider certifications, board certifications, they will take you or give you links to these other areas. But it's you can search on the American Board of Addiction Medicine website. You can search on the American Board of Preventive Medicine website and find addiction certified providers. So those are the resources. That's just certain ways you can do it. It's not hard to do. Question: is it required that all levels of care provide access to all FDA approved medications for opioid use disorder, or at least two of them with a different mechanism of action? The answer is no, it's not a requirement. The levels of care are really about what facilities are available and what supervision is available, whether or not there's medical resources available, whether it's 24 hours, whether it's residential, things of that nature. They don't necessarily, they talk about, it should be, for example, psychiatric care available or behavioral management care available. The criteria doesn't say, and it must be this type of behavioral management. They leave that up to the clinician, but the availability of behavioral health care is, again, one of the criteria for distinguishing the different levels of care. There is a section that talks about whether or not your facility is a OBOT, or which is a office based, for example, a buprenorphine clinic, or a OTP, which is essentially the methadone clinics. And you don't, if you're a methadone clinic and that's what you do is just provide the methadone primarily, you don't have to also do buprenorphine or naloxone or things of that nature. You can do what you do, and you don't have to offer every level of every modality to get a certification, to qualify. But you do. It's about, do you have enough of staff and supervision and things of that nature to justify being at a certain level of care? What happens when someone needs a higher level of care, but it is not available in the community? Well, that's very common. Is it wrong for a provider to treat someone in a lower level of care if a higher level of care is not available? Well, I'll answer the second question first. It's never wrong to treat somebody. And if you do the best you can, and if you feel like you can get them somewhere else, and you decided through your assessments that they need a higher level of care, but it's not available and it's not going to happen, then you give them the best care that you possibly can, and document what you're doing there, and explain why you've made that decision. So it's not wrong. It's never wrong to provide care. Now, if patients are going to have autonomy here for the most part, they really are, and it's if somebody is just not going to go to residential, but they will see you in your office, but maybe you can get them to the point where they're ready for something else. So it's not just whether it's available; it's whether you can get them to go do it. So what happens when someone needs a higher level of care but it's not available in a community? Well, you do what you would do with, I guess, any other medical condition. If somebody has uncontrolled diabetes or a heart condition or whatever, and you think they need a cardiac cath, but you don't have it in your community, well, you try to get them referred somewhere else to where they can get it. And if they refuse to go or can't go or don't want to go, you do the best with what you've got. So it's never wrong to treat somebody to the best of your ability, but understanding that and through this criteria, through this assessment, you can hopefully understand and then give people the best information so that they can make this decisions as well. It's tough sometimes because the disease of addiction doesn't make you think clearly, but it's just it's really a challenge. But I don't think it's ever wrong to give somebody the best care you have available. Some scenarios. Following slides look at specific scenarios. So I'm going to walk us through a few of these. These should be kind of interesting, kind of, I don't say they're fun, but I looked at these last couple of days and maybe you'll recognize some of these patients. Okay, I've got 3 of them here. Here's the first one. A toxicology service is consulted from the emergency department as the county jail staff has brought a 21-year-old Hispanic woman who's 18 weeks pregnant. She was arrested on a warrant, has been incarcerated for just over 24 hours, but during that time, she developed nausea, irritability, diaphoresis, anxiety, and yawning. She was noted to have stigmata of intravenous drug abuse and told the intake officers that she was going into heroin withdrawal. So she knows what heroin withdrawal is, and those symptoms there, the nausea, irritability, diaphoresis, that's definitely consistent with heroin withdrawal. So we've got a really crisis on our hands here. We've got a woman who is got a baby on board, and when patients are pregnant, that is often a really great opportunity to get them into treatment because they're seeing some clarity. There's something about being pregnant that really motivates patients just to seek treatment. But this is a situation where somebody would need to be monitored very closely, inpatient and intensely monitored and treated for the withdrawal as well, because that's a very dangerous situation for the baby, and miscarriage could happen. It can be it's very dangerous for the mother as well, and so she would need to be admitted intensive medical care. So that's hopefully that's obvious to most people. The next scenario: a 54-year-old woman with chronic pain due to inflammatory arthritis presents to the emergency department stating that she is having a flare of her arthritis, but is out of her OxyContin and her immediate release oxycodone. She's aware that it is too early to fill her prescriptions, but she insists that she will be traveling out of state and really needs her medications. She presents on a Saturday when her clinic is closed, and her primary care physician is, quote, on vacation. So this is a situation where, again, I mean, it's hard to know what's going on here. This is somebody who's coming on the weekend. They say they're on this medication, oxycodone, and hopefully you'd be able to confirm that by doing the Casper, and you'd be able to look that up and confirm that. Her doctor's on vacation, but there should be somebody covering for her doctor, maybe. So you could figure out some more information from that. But the fact that she is out early with OxyContin and immediate release oxycodone is very worrisome. But you don't know what's going on here. I mean, this patient certainly could have uncontrolled pain. We don't know whether this is addiction, an opioid use disorder. We do know this is a problem here. I also understand that if I do a drug screen, I find out that she does have, you know, oxycodone in her system and doesn't have heroin or doesn't have something else, but you can do a drug screen and see that okay, it's based on what that says. You're going to have more information. You can do the Casper report, try to contact the physician or the doc on call. Try to get as much objective information as possible, and then again do your ABCs. What's our acute withdrawal potential? What other medical issues are going on with her? She's having a flare of her arthritis. Are there other things as well? And then think about the behavioral aspects of this. And even though this is not addiction, you can think about the other R's as well. What is what's going to happen if we treat her? If we, and how are we going to treat her? I mean, there's no, I guess, right answer to this based on just this paragraph. But if she truly is on this medication, she very well could go into withdrawal. And so you might want to give her something, follow her really closely here, but you're going to want to get more information and then decide based upon the facts. But the main thing I take from this scenario is that we don't know what's going on here. We don't know if she's got addiction. We don't know if she truly has arthritis. We don't know if her doctor truly is on vacation. Situation where you want to be compassionate. You want to go through those 6 dimensions. You want to do your assessments, do your medical assessments as well. Gather as much information as you can, and then make a decision that is going to address the biopsychosocial issues you see presenting before you. So it's kind of that one there. And this points out also, you can see that if you think about those ASAM criteria, the ABC, RRR, if you're thinking about that, you can apply that to even difficult cases like this. And I got one more to show you, which is even, I think, more maybe initially looks problematic, but again, it's not so hard if you apply those criteria. This is John. John's a young person. John's just 23. He's checked into the emergency department with severe gastrointestinal pain. And this is his 6th visit to the same ER with the same symptoms. So he's a frequent flyer, as they say. He is visibly in discomfort and it requires opioid pain medications. Now, John tells you he has been taking opioids for years to deal with flare-ups of whatever's causing his gastrointestinal pain, and which includes vomiting and diarrhea, and it led to a 40-pound weight loss and 5 colonoscopies. The latest flare-up occurred after he ran out of his pain medication and couldn't get a refill. John gets very angry and defensive when the staff suggests he's addicted to painkillers. He contends that he wouldn't be on painkillers if the doctors could figure out what's wrong with him. When he calms down, you're able to learn a little more about his past. He tells you he has battled anxiety and panic attacks since he was a kid and diagnosed with learning disabilities. Currently, he feels the only relief of his emotional and physical pain is pain medication, and that he is trapped in this situation. Finally, he adds that lately he's experienced auditory, sensory, and visual hallucinations. So, okay, just if you step back from this and you think about those criteria, if he has out of his pain medicines, he has some withdrawal potential. You want to assess that. Clearly he's got a lot of biomedical things going on here. What is causing this gastrointestinal pain? It's hard to say. If he says no one's figured it out, maybe you're not going to figure it out right there in the emergency room. But of course, you still have to go through, the acute things. Like could be an appendicitis. It could be. This is an example of somebody who everything he's saying here could be exactly legitimate and correct. So you've got to listen to these patients, even though and unfortunately, the staff, when he says that they accused him of being addicted to his painkillers, you can't make an assessment of somebody being addicted, as I know you all are aware, at an ER. You can simply say these behaviors are worrisome, and we're going to base our therapy on our concern that these are red flags or worrisome behaviors. But addiction is a diagnosis we make over time when you get to know somebody. I mean, he very well could be, but he also could be somebody who's been managed poorly throughout his life. It's very difficult to manage chronic abdominal pain. And once they get on opioids, and it does help for a while, it does. If somebody does have an emotional issue or a psychiatric issue, oftentimes the opioids will calm them down and will help them cope with the psychological issue. But it's temporary, and when it wears off, it can be worse. That's not really addiction. That's chemical coping and basically inadequate, if not poor, medical management. So I think the main takeaway from this is that you've got to meet them where they are. When they do tell you they have these medical conditions and these medical symptoms, they do need to be believed. They have to be addressed, and they have to be you have to work them up. And don't just jump to the conclusion that somebody is addicted when in this situation, everything he's saying could be the legitimate consequences of the way he's been managed in the past. And he may not need addiction treatment. He may need something that's similar, close to addiction treatment. But then again, he also may need it, and that's something that once he calms down, once you address um, the A, B's, and C's, you can then uh, get into exactly what's going on emotion with him, and he may then, once he's calmed down and once his acute pain and his anxiety has been kind of addressed, then he might be able to open up more to you. But again, this is somebody that points out that it, although it looks like there's a lot here, you've got to go from the standpoint of it could also all be legitimate as well. Okay, so that's the three scenarios. There's a lot to think about in those three. I think that we can open it up for any other questions we might have now. And John, if you'll kind of monitor that, and if you want to run some questions by us or by me, I'll be glad to help you with that.
Absolutely. First, I'd just like to thank you for answering those questions and giving a review of what we covered last week, as well as going through those scenarios. I think that perspective is really helpful. So at this point, I'll open it up. So if someone has a question, you can feel free to unmute yourself and ask a question. You could also just type it in the chat, or if you would rather I ask it for you, you can send it to me privately.
I have a question. So whenever we're doing intakes, sometimes a judge will order a specific type of treatment, and they clearly haven't done any kind of ASAM or any kind of assessment, but it's like that's the only thing that someone will be released to. And I didn't know if there was any way to communicate that to like a prosecutor or a judge that that's maybe inappropriate, like the
Well,
level.
I think that this is a situation where if you can communicate to the judge that you see things maybe differently, and what you're saying, the reason why you see differently is based upon criteria from the American Society of Addiction Medicine, and then you can show them because of I've assessed this patient, and I can see that they need this level of treatment, and it's based upon criteria it's accepted nationwide. I My experience is that the judges that I've talked to are very open to that kind of thing. A lot of them seem like they're from their communities, and they have family members, or they have constituents or whatever, and they bring to the bench, their a lot of preconceived ideas about how this is what really should be done. But they're also open to when somebody who's in the field and doing this can say, no, I actually, let's try, we need to do this, and this is the reason why. So this is an example where the ASAM criteria and the levels of care can really help you get the patient to where they need to be. Another reason to learn it and to be familiar with using it. It's kind of like, when I go with I do a lot of pain management. So that's my I guess my first specialty. And a lot of times I'll ask for a treatment, and it'll be denied by workers' comp, and then it'll have to go to before a judge or something like that. And typically, what's happened is that the insurance company has reopened the case, and they've asked some reviewer in some other state somewhere, usually, to go look at the records, and they'll point to the what's called ODG guidelines, and the guidelines will say that this patient should not have physical therapy or should not have an epidural or whatever treatment I wanted to have, maybe even pain medicine, because it hasn't been proven or this or that. And when I have to go before the judge, the for the work comp case, I'll give him my credentials and I'll say, yeah, and I'm a smart person and I'm experienced and I see the patient and all this kind of stuff. But it's really helpful when I can say, and based upon the recommendations from for example, the American Society of Interventional Pain Physicians, this is what the patient's going to have, and I'm going to do something. That's right in line with what they recommend. Or even I can say, go to the FDA approval on the package insert for the medication. It's FDA approved for this condition. Judge, this patient has this condition. There's no reason that they should be taken off of it because of some other guideline from somewhere else. So it's rather than just use my good name or my experience to kind of convince a judge, when I have another guideline or something else to give the judge a reason to go with what I'm asking, it really, really helps. And that's what I see the ASAM criteria and the ASAM levels of care doing for us, because it's really there's really no other thing out there like that. A lot of addiction treatment, it's all over the place. Some people believe that you need to do non-medication involved treatment. Some people don't believe in it's at all the best way to do is with buprenorphine and things of that nature. I would say the evidence would point in the other direction, but we do know that there are lots of models and lots of ways to treat people. And it's nice when you're recommending something to have a standard way, a standard that you can show the judge, so that the judge will be able to base their decision on something more than just their gut feeling. If you want to learn more about this, and again, this is a lot to go through. It's way too much for 1 hour. But again, remember, my goal was that you're familiar with it and that you kind of know they exist, the importance of it. And if you go to the ASAM website and just start looking around on that, you'll see lots of tutorials and lots of help with getting comfortable with this. It's something that's here to stay, and it's gaining momentum. So I really think it's worthwhile for us to embrace this.